All right, welcome back, everyone. So we're going to pick up here, and we're going to start looking specifically at our red blood cells, right? So looking specifically at our erythrocytes, right? So recall that prefix erythro refers to red, and then cyte means cell. So these are, of course, our red cells, our red blood cells. So these are very small formed elements, as we'll see when you look at them in a blood smear. Um, you can very easily see them. They're by far the most abundant, the most common formed element. Recall that formed elements, we have our red blood cells, white blood cells, and our platelets, and the vast majority of those are red blood cells, right? So they're very small. They lack a nucleus, as we mentioned in our previous part. And recall the lack of a nucleus. I think I didn't tell you what the purpose of the red blood cell lacking a nucleus was, so I'll fill you in. The lack of a nucleus allows for more space for the cell to have more hemoglobin. And so we'll talk about hemoglobin here in a moment. But for now, note hemoglobin is the structure responsible for binding oxygen, right? So it binds oxygen, and that oxygen is then transported in the red blood cell, which is in the blood throughout the body to our various tissues, right? The red blood cell also has a biconcave shape, so meaning it kind of dips down, it's concave on either side. And again, this increases surface area for hemoglobin, but it also allows the cells to kind of stack together as they're moving through very small capillaries, right? And then, of course, we know that it is transporting oxygen as well as carbon dioxide. So oxygen is not the only gas that binds to hemoglobin. There are lots of other things. Carbon dioxide, carbon monoxide, nitric oxide, all these things can actually bind to hemoglobin, and in some ways have a very serious effect or seriously influence our ability to transport gases to our body. So if we look at our erythrocyte structure, again, you can hopefully see very easily the biconcave structure of a red blood cell. If you look at the top left image of this red blood cell right here, so you can kind of see this dip, this concave structure here, and you can also see it down here. Incredibly thin, right? Incredibly thin cells. Again, they're lacking a nucleus, and so when you don't have the nucleus, you have space for all of the different hemoglobin molecules, right? So you can see roughly 280 million hemoglobin molecules in that single red blood cell, and as we'll see in a moment, each hemoglobin combined to 4 oxygen molecules, right? So you can do the math. 280 hemoglobin molecules times 4 oxygen molecules per hemoglobin, the number of oxygen molecules that we can transport, right? So it's an incredibly large number. You can also see in the bottom image how they kind of stack together in very small capillaries, right? Small arteries, arterioles, small capillaries, right? And the red blood cell is a really good example of a structure-function relationship, right? So how one informs the other, right? So in order for the cell to fit through small vessels, in order for the cell to easily transport large quantities of oxygen, you need a cell that has a particular shape, right? And again, some structural components, again, the lack of a nucleus and that biconcave structure, right? So the red blood cell is a good example of a cell that has the structure-function relationship. And in general, we have our red blood cells for about 120 days, right? So 90 to 120 days, so think something like 3 to 4 months. And this has clinical implications. If you've ever heard of, we won't go into a lot of detail on it now, but if you've ever heard of something called A1C or hemoglobin A1C, this is the measure of our red blood cells' contact with glucose in our blood, and it's a way to manage or a way to determine the long-term management of blood sugar in a patient with diabetes, right? But it's a function of the lifespan of a red blood cell being 120 days. You can check the A1C over that span, 3 to 4 months, and see how well somebody has regulated their blood glucose over those 3 to 4 months, right? So again, the hemoglobin molecule, it's similar to myoglobin in some way, and not so similar in other ways. Recall myoglobin is kind of a oxygen storage molecule that we find largely in our muscles. So big thing for hemoglobin, it's transporting and binding gases, namely oxygen and carbon dioxide. You call hemoglobin that has oxygen bound to it you call it oxyhemoglobin, and when it does not have it, you call it deoxyhemoglobin. And so blood that has oxyhemoglobin, or a large percentage of it with oxyhemoglobin, you call that oxygenated blood, right? Blood that lacks oxygen bound to hemoglobin, the deoxyhemoglobin, you call that deoxygenated blood, right? Now, deoxygenated blood, that name is sometimes a misnomer. It kind of gives the idea that deoxy, there's no oxygen, when in reality, our blood always has oxygen in it. Even quote unquote deoxygenated blood, there's always some amount of oxygen, right? So sometimes I may refer to it as oxygen-rich blood or oxygen-poor blood, right? So again, meaning lots of oxygen bound to the hemoglobin or not a lot of oxygen, right? Now, the structure of hemoglobin, it's made up of two things. It's made up of something called heme and globin, right? The heme is a pigment, okay, in the middle, and there's an iron bound to it, or an iron located there, and then the globin part is protein, right? So it's made up of amino acids, just like all proteins are. And so you may have heard of sickle cell disease or sickle cell anemia. This is due to a single point mutation coding for our hemoglobin molecule. So again, a single error in the protein synthesis process can result in an abnormal form of hemoglobin, which results in an abnormal shape of the hemoglobin, which affects the cells and how they move through blood vessels and how they transport oxygen as well, right? And again, for our hemoglobin, 4 oxygen molecules, right? 1 oxygen molecule on each of the heme units in the hemoglobin, and again, each heme unit contains an iron. So 4 heme units, 4 irons, combined 4 oxygen molecules, right? And again, there's roughly 280 million or so hemoglobin molecules in a single red blood cell, right? Now, the way in which oxygen and other gases bind to hemoglobin vary. So other things like carbon dioxide, and especially something called carbon monoxide. You've heard of carbon monoxide poisoning. These typically bind to hemoglobin much greater. They have a much greater affinity, which kind of means an attraction for, or an attraction towards. They have a greater affinity to hemoglobin than does oxygen, right? So this is why carbon monoxide poisoning is so dangerous, because it prevents it offloads the oxygen from your hemoglobin and prevents the oxygen from binding, right? So it can be incredibly dangerous. Now, for our hemoglobin, and I'll show you an image here of hemoglobin. So again, you can see here our different globin chains, right? So these proteins, the heme in the middle, and then the iron associated with the heme right here, right? So this is where our oxygen is binding. Now, hemoglobin exhibits something called cooperativity, right? Or cooperative binding. Okay, cooperative binding. What this means is that as you have one oxygen molecule bind to hemoglobin, which remember, it can bind 4. So as you bind one oxygen molecule to hemoglobin, that increases hemoglobin's affinity for the second oxygen molecule. And so it binds more easily, which makes it more easy to bind the third oxygen molecule, which makes it easier to bind the fourth oxygen molecule. So this idea of cooperativity or cooperative binding means that as you bind more oxygen molecules, it makes it easier for the subsequent oxygen molecules to bind, right? For other similar molecules like myoglobin doesn't necessarily show that, right? And so what we'll see, we'll look at or you can look at it as well. It should be in your text. There's a graph or a chart referred to as the oxyhemoglobin dissociation curve, and it shows how oxygen concentration or the saturation of hemoglobin with oxygen changes at different pressures. But it's also affected by the presence of oxygen on the hemoglobin. So again, the more oxygen you bind to hemoglobin, the greater its affinity or attraction for other molecules will be as well, right? Now, for our red blood cells themselves and for this hemoglobin, you can imagine how if you are in an environment, if you're in some type of setting in which you have a poor oxygen count, or something like that. Um, if you're in that type of situation, you are unable to bind and transport adequate amounts of oxygen. And so we produce a hormone in our kidneys called EPO, or erythropoietin, right? So you may recall the term of making red blood cells is erythropoiesis. So erythropoietin stimulates erythropoiesis. It prompts the production of red blood cells, right? And so we have this EPO release, or this EPO secretion, in periods in which, or during periods in which we have low blood oxygen, right? Or we have poor oxygen in our environment, which results in poor blood oxygenation, right? And so we stimulate that process that we looked at in one of our previous videos of making red blood cells, right? And so you begin to make this, or you begin to produce more and more red blood cells. And so as you produce more red blood cells, of course, with the red blood cells you have hemoglobin, and we said that hemoglobin binds oxygen, right? How many oxygen molecules? It binds 4. And so if you have more red blood cells with more hemoglobin, you can bind more oxygen, right, with the more hemoglobin. And so what this is doing is this is a kind of homeostatic mechanism to help control and maintain the amount of oxygen that we're able to bind and carry in our blood. So you can see here, erythrocytes increase blood's oxygen carrying capacity. This increases blood oxygen, or the increase in blood oxygen inhibits EPO. So of course this is a negative feedback loop, unlike a positive feedback loop, right? Now other things like testosterone can stimulate EPO production. So this is why we said in one of our previous parts that on average males typically have a higher hematocrit because they on average have greater levels of testosterone, and testosterone stimulates EPO production in the kidney, right? And then of course environmental factors. So if you go to Colorado, if you go to Red River, New Mexico, you can get up to 10,000 plus feet. You go to Denver, something like that. You are at an altitude in which the oxygen levels are much lower, right? And so if you're not from that area, if you're not from these high elevation areas, and you go there and you hike, or you go run, or you go bike, or walk, or something, you may notice that you are more winded, if you will, right? For lack of a better term, your breathing is more labored, right? It's because you don't have an adequate ability to bind the little oxygen that is there. And so what you end up with over time is EPO release, EPO secretion, stimulating red blood cell production, allowing you to kind of accommodate or compensate for that low oxygen level, right? Now, here's a kind of a graph or a schematic of how EPO is being released, right? So basically what we just said, there's poor oxygen levels in the blood. We are stimulating the release of erythropoietin in the kidney. It's going to go to our red bone marrow, right? So of course our red blood cells, along with our white blood cells and platelets, are made in our red bone marrow, right? So think epiphyses of long bones, parts of our flat bone, so like our ilia, right, in our hip. We're stimulating the production of red blood cells. We increase the number of erythrocytes in our blood, and we increase our oxygen carrying capacity, and then that's acting via negative feedback to decrease the amount of EPO being released, right? Now, EPO can be given in clinical settings as a medication, as a drug to assist patients who are anemic, right? So anemia is basically just you have a decreased ability to bind and transport oxygen for some reason, right? There's sickle cell anemia, and there's iron deficiency anemia, and there's pernicious anemia. There's various different types. But EPO can be given for those reasons as well. Maybe it's a patient with cancer and they're on chemotherapy and it's destroying their red bone marrow, so they're taking EPO to assist with that. You can also give EPO, or rather I should say take EPO, in a context called blood doping. And so blood doping is typically discussed in a athletic context, and this is in a couple of different ways. One, it can be like what we just said, giving the drug erythropoietin to the athlete to enhance or to promote the development of red blood cells. It could also be self-donation of red blood cells. So meaning an athlete will give blood, right? They'll take away a certain number of red blood cells to accommodate for that lack of red blood cells, now their body produces EPO, or begins increasing the amount of EPO that is secreted. That results in increased red blood cell production. So you increase the red blood cell levels back to their, kind of pre-donation level. And then before the athletic event, if it's cycling or if it's running or something, you then give the erythrocytes back to the patient who initially donated them, right? So it's this idea of self-donation, right? And so again, you're artificially now increasing the number of red blood cells, right? So if you think in a athletic context, if you have more red blood cells, you can bind more oxygen. If you can bind more oxygen, you can deliver more oxygen to your tissues. If you deliver more oxygen to your tissues, you're able to synthesize and produce more ATP. So now you have a greater aerobic capacity, right? A greater aerobic endurance compared to other individuals who did not do that, right? And so it's a form of cheating, and it's illegal in pretty much all athletic contexts, right? If you've heard of Lance Armstrong, right? He got in trouble for blood doping, which he got the brunt of the media attack, but turns out pretty much all of the other cyclists were doing it as well. So he was doing it, but he got caught, and he was a big name, so he got a lot of the rap for it. So when you think about blood doping, and you increase the number of red blood cells, right? What could be the effects of that, right? So something we talked about earlier was we talked about how you can increase the viscosity of the blood, right? So meaning the thickness, in other words, of the blood by increasing the number of cells, right? So essentially you're adding more and more cells to the blood, increases the viscosity. If blood is now thicker or more viscous, it's requiring the heart to pump at a greater with greater force, right, to move that thicker blood, right? So imagine instead of pumping water or blood, imagine pumping syrup or something like that, right? So it's going to have to work harder, which can cause both heart damage, it can cause vascular damage as well, right? And of course, as we mentioned, it's illegal, right? You can't use it in athletic sense, and that should make pretty intuitive sense once you know the effects, right? Now, when we talk about the breakdown of red blood cells, right? So red blood cells, we said earlier, they live about 120 days, right? So 90 to 120, 3 to 4 months. So once that time has elapsed, right? Once they have met the end of their days in your body, there is a process by which you can recycle some of the parts of the red blood cells, right? So the globins, right? So you have hemoglobin. So the globin or the globin, and you have the heme. The globin part, which is the proteins, right, are broken into amino acids, right? And so we can use those amino acids for other processes to resynthesize hemoglobin in the future. You can reuse the iron as well, so it's transported by something called transferrin, and then it's typically stored in the liver and the spleen as well, right? And then there's different storage proteins in cells and in the liver called ferritin and hemosiderin. So you can reuse the iron component as well. So you're not just getting rid of all of these molecules at the end of the life cycle of the red blood cell. The heme itself undergoes a slightly different process. It has a different fate, in other words, right? The summary of it is it's ultimately going to be broken down. It's going to be added into bile. Bile is part of our, it's converted into something called bilirubin here, and then it's added into bile, and bile is what we make in the liver, we store it in our gallbladder, we release it into our small intestine, our duodenum, the very first part of our small intestine that receives contents from the stomach, and then that bile helps with fat digestion in our small intestine, and then that bilirubin, which is incorporated into bile, is converted into several intermediate molecules, one called urobilinogen, stercobilin, and urobilin, and these are either eliminated with our feces, in the case of the stercobilin, or in the case of this urobilin, it is reabsorbed and then incorporated into our urine. So it goes back into the blood, it goes to the kidney, it's filtered at the kidney, and it's excreted in the urine, and again kind of gives our urine that kind of yellow tint that we typically associate um, with urine, right? But the idea here is the heme part is ultimately broken down and eliminated. The globin part, right, the protein aspect is largely reused, right? It's broken down and the amino acids are recycled, right? So this is somewhat of a kind of a summary of some of that content, right? So big thing here, we have our breakdown, right, of parts of our hemoglobin. Here's our heme, right? The globin is broken down into AA. This just means amino acids, right? And then the heme is broken down into these various components, right? Biliverdin, bilirubin. The bilirubin is incorporated into bile in the liver and gallbladder, added into the small intestine, and then from there the bilirubin is broken down into stercobilin, which is eliminated in our feces, right? It gives the feces its characteristic brown color, and then the bilirubin may be reabsorbed back into the blood, transported to the kidney, filtered, and then eliminated in our urine, right? So there's several different processes that go on concerning the breakdown and recycling of hemoglobin, right? So all this to say, with red blood cells, with hemoglobin, we talked about oxygen binding, is this idea of anemia, right? So anemia is essentially a decreased ability to carry and deliver oxygen, right? It may be due to several different factors, due to an abnormal form of hemoglobin, right? It may be due to something like sickle cell disease, sickle cell anemia. It may be due to blood loss, right? So hemorrhagic anemia, essentially you have lost so much blood that you now have a decreased ability to bind and transport oxygen. It could be pernicious anemia. So this second to last one you see here, pernicious anemia is when you have a decreased ability or inability to absorb vitamin B12. Vitamin B12 is necessary for the synthesis of red blood cells, so to make red blood cells. So if you don't have vitamin B12 and you can't make red blood cells, then you can't bind as much oxygen, right? And what you're lacking is something called intrinsic factor, which is this molecule produced in our digestive system that is necessary for the absorption of vitamin B12. So essentially you lack the intrinsic factor, which means you can't absorb vitamin B12, which means you can't synthesize adequate amounts of red blood cells, which means you can't bind enough oxygen, so you end up with anemia, right? So in this case, in pernicious anemia, focus on this for just a moment. If you lack the ability to absorb vitamin B12 from the digestive system, how then are you going to get your vitamin B12? I'll give you two options. Should you take a vitamin B12 supplement? So a supplement, you take it as a pill, you swallow it. Or do you have to get vitamin B12 injections? Right? Which one do you think? Hopefully you're saying that you have to get the injections, right? So if you can't absorb vitamin B12 with pernicious anemia, is taking a supplement going to do you any good? Right? If you consume it orally, swallow it, goes into your stomach, intestine, are you going to be able to absorb that? No, because you still don't have the intrinsic factor, right? So instead, you'll have to get vitamin B12 injections, right? You get intramuscular injections, and I forget if they're once a month or something like that, but you have to get an injection of the B12 so it goes directly into the bloodstream instead of being absorbed into the bloodstream, and then you can use that, your body can use that B12 to synthesize erythrocytes, right? So we're going to stop here, and then we'll do our next part, the kind of last part of this initial part one, talking about some of our different blood types.